Okay, good morning. Can you guys hear me? Good morning, everyone. We're so excited to see you guys here. We weren't sure how many people would come in. So I'm Peggy Latari, family physician, and this is Grant Okawa, who's an internist. And we gave you part one of this talk in MD1. Does anybody remember that? Okay, good. Most importantly, we are MD4 tutors. Yay. So I see most of our class, our group here. Way to show up, guys. Thank you. So I'm going to do a quick review of part one. And I know you guys are super busy, but I have watched Grant do the biology and physiology several times, and I always learn more. So I would really recommend you go back and watch part one again. But I'm going to do a really quick review of it today to kind of set the stage for what you're probably really interested in is like how do we treat obesity now in 2025. It's very different than when I went to medical school. By the way, my friend Shelley Rutherford is here visiting from Northern California. She and I moved to Hawaii together. We did our residency together in Minneapolis and moved here for our first job a long time ago. She's here visiting. So obesity is a chronic disease. You would think that it would have been called a chronic disease a long time ago because the prevalence is so high. As I mentioned, no matter what specialty you do, you're going to see people with this condition and you're going to want to help them. Weight stigma is a definite thing. You probably remember we asked you the question and you all aced it, that the place that people get the most stigmatization is in the healthcare sector. So we have our own biases and we have to be aware of those biases. An individual inherits this genetic potential, but it's not determined destiny. So environment can have an influence, both good and bad. It's driven by an interaction of multiple factors that are beyond lifestyle, beyond willpower, many of which are outside that person's control. And energy regulation is very complex. It also involves the reward system, the learning system, the motivational system, executive cognitive function. It's extremely complicated how we regulate our energy. The set point is driven to kind of go high, which we don't like, but that's just the way it is. So this metabolic adaptation, if you ever lose weight, if you ever gain weight and try to lose weight, your body will constantly be trying with increased ghrelin and decreased metabolism to maintain that higher set point. So what do we do? Luckily, we have some things that we can do to help people against that biology that's very powerful. So today we're going to talk about the lifestyle, behaviorally based lifestyle. We're going to talk about nutritional interventions, movement interventions, and probably most importantly, the pharmacotherapy interventions that we have now and how to apply principles to the use of these medications. And then we're going to touch quickly on the bariatric procedures, which are actually, there are fewer and fewer that are being done in our country because of the power of the GLP-1s. It's a very interesting time. So to start with, I just want to say a couple words about how we talk to people who have obesity. And words really do matter, no matter how we talk to people about whatever they have, but especially in this case, it's actually been studied that people, it didn't come across so completely. So, but just you just want to avoid the word obesity and morbid obesity. We talked about this briefly yesterday in PBL that what you put on the problem list is seen by the patient. So this is a kind of a conundrum, but you definitely want it on the problem list, and then you have to have that conversation with the patient about, I know that's not a great word, and when you're actually talking with them using the words like weight, unhealthy weight, high BMI, patients strongly have a preference for that. I think you just had a lecture on MI, if I'm not mistaken. So I put this in because truly MI is one of the key ways that we intervene with our patients. You probably know all this stuff. I just highlighted, I think MI can be summarized by this statement of ask, don't tell. Like we have this tendency to tell people what to do. We have a great idea for them. But if they don't feel motivated by that or they don't think that's going to work for them, it's not going to work. There's a lot of evidence that telling is not as effective when a behavior change is needed. So asking people what they think and so on is really helpful. So the spirit of motivational interviewing is really this partnership versus lecturing, evoking, like figuring out what they want, what motivates them versus telling them what we think is important based on the research or whatever. being accepting and non-judgmental. And the folks who literally wrote the book on MI added compassion to the end because they felt like people were starting to use this in a very manipulative way, kind of like a Jedi mind trick way. And that's not what MI is. MI is a compassionate approach to people who are struggling with something. And so instead of avoiding them or judging them, we use the MI. I'm not going to go through these. I'm sure you just heard about the tools that we use. And so just a clinical application of how you might use your words is, like, I noticed your weight is higher than last time. Is that something you're interested in talking about? And if they say no, then we move on, right? Because they're not always ready. You can really save you time if they're not ready. I know you've tried to lose weight in the past. What's worked for you? It can be frustrating to maintain or lose weight. There's an empathic statement, one of my favorites. How's that been for you? What ideas do you have? These are the kind of words that are much more effective than, I notice how, your BMI is now 40, and that's terrible. Do you know what the risk is? Blah, blah, blah. That's kind of sometimes our go-to. It's not very helpful. It's very judgmental. So really, behavior therapy is the cornerstone of weight management and any disease that has a lifestyle component. So one of the things that for us to think about is, why do people eat the way that they eat? Why do people live the lifestyle that they live? And there's a lot of reasons. There's a lot of strong physiologies, much of which we talked about last time, the biology of the neuroendocrine system and so on. There's all kinds of CNS things, like the smell of food, the taste of food, somebody else is eating, and maybe it's time for me to eat. There's mental stress. I don't know about you, but when I was in med school, I did some eating that wasn't necessarily related to hunger. Right? Yeah, timing and emotions is 12 o'clock, must be time to eat. Am I hungry or not? It's not really always a question we ask ourselves. This environment, the amazing amount of food that really, no matter where you go, they're selling some kind of food. Definitely, there's sometimes an information gap. There's this whole idea of reward. Again, I completely relate to this. I had a really hard day. The test was really hard. I got in a fight with so-and-so, and I think it's time for ice cream, right? So very, very common in my practice to hear people talk about the end of the day reward. And the reward is usually not broccoli, or a kale salad for some reason, yeah. So then there's lack of time, lack of resources. It's expensive to buy healthy food. Sometimes drive-thrus are cheaper. They have a 99-cent deal. And then, unfortunately, we don't have time today to talk about the eating disorders, but there are definitely some eating disorders that I'm sure you'll cover somewhere else that drive people to eat. And then what about exercise? So again, physiologic reasons, health conditions that keep people from exercising, hurts, or they get too tired. There's this environmental concern. Is the built environment safe for them to exercise? Again, lack of time and resources. And then disinterest. Like, you will definitely meet people who will say, I've never exercised a day in my life. I don't like to get sweaty. Maybe some of you in the room, I just don't like it. And so that is something that we have to work with people and try to help them overcome. So when we talk about behavior therapy, it needs to be something that's doable, that we can measure, that has some evidence behind it, but most importantly, that the patient can own themselves and can say, this is what I want to try, or this is what has worked for me in the past. So there's a long list of behavioral, basically cognitive behavioral therapy types of things that we teach our patients. And often we work with someone like the psychologist that was just here, or a clinical social worker, to teach some of these skills. And some of them are very obviously like goal setting and stress management. Self-monitoring is, having people maybe track their intake, actually enter the food that they're getting, and there's a lot of aha moments there. Choice architecture is, making the choice at a time in the process of between buying the food and eating the food that makes sense. So rather than having the food on your counter right in front of you, try to make the decision when you're in the grocery store, or even before you go to the grocery store, having a list of things. So those are the kind of things we talk to patients about, like trying to make the choice that you want to make for the long run earlier in the process, so that you aren't stuck there staring at the Oreo bag and thinking, how do you say no to Oreos? So there, you do have a document in your drive that goes into more detail of these, so you might want to review that. Oops, so I was going to ask you what we think the most important one is, but I couldn't. So we do think the self-monitoring is super important. I had so many patients, even myself, when I track my own calories. There's a lot of great apps out there, Lose It and Noom, and lots of apps that you can track. If you haven't ever done that, you might want to do it. It's very eye-opening to see certain foods that you like or you eat frequently that are super calorie dense, and those are things we start working with people on. So just a few words about mood and mental health. So when we ask people to make changes in their lifestyle, it takes a lot of concentration, it takes focus, it takes energy. And if you're struggling with mental health problems, mood problems, and so on, it's hard to do that. And so we kind of set people up to struggle more than they need to if we're not also co-managing that. So we always say mood comes first and then weight management. We definitely in our program, we screen people for depression and anxiety and childhood, adverse childhood events and other things, because you often will not get the results you want if the mood is an issue. So just a few words about behavioral therapy, that you may see an initial improvement when people start making lifestyle change, but often there's a plateau. Sometimes there's even a relapse or a lapse. And so talking about relapse and lapse identification and how to respond to it is super helpful. A lot of people who are in this situation have really black and white thinking, and they think if they have a bad day or make a bad choice, then I might as well just forget it for the whole week, and then they just add more calories. So something that we talk to them about. And then if you see a lack of self-care, if you see people that are just struggling and they can't make some changes, then think about mood disorder again. Think about is stress management an issue for them. Think about childhood trauma. I was shocked when I started my bariatric practice how much childhood trauma we saw in our patients. All right, so we're going to move over to the nutritional therapy. So I listed a bunch of common kind of diets that we see out there. Anybody have a sense of which one of these would be the best for long-term weight loss, if you just had to guess? Just yell out a number, maybe. 7. Mediterranean. There's a lot of good things about Mediterranean diet. Well, it's kind of a trick question, because as it turns out, it almost doesn't matter what macronutrient you decide to eat. It's if that is something that you can sustain. So the truth is that no diet works for everybody, and every diet works for someone. And so our goal and our work is to figure out what is the way that that person wants to eat, and then we need to restrict their calories. So I'm not going to go through these slides one by one, just to show you there have been so many studies to kind of prove this. And this is one that had 4 different combinations of macronutrients. You can see that the weight loss line was exactly the same in all of them. And then they studied actives and Ornish, and then they studied low fat versus low carb, and then they studied all these other ones. Every single study that's ever been done has shown the same results. Everybody loses weight when you restrict their calories. And so finally this editorial came out and said, we should probably stop doing these studies, funding all these studies, because we know what the answer is. And the most important question on the bottom line is that, are they going to adhere to that? Is it something that they feel like they can do and kind of do as part of their natural life, not just for this week or next month or next year, but kind of forever. But if you want to have some guidelines, this is what we typically do: 12 to 1,500 calories for women, 15 to 18 for men. Or if you've had them do some tracking of their calories and you know kind of what their overall average calories is, just take 500, 750 calories off of that, and that's the goal that we give people. So you do have to limit calories in order to lose weight, but the kind of calories and the way that they limit really comes down to the patient preference. So I just want to say a few words about intermittent fasting, because it's a very popular topic right now. I have a feeling that maybe some of you in the room that are doing this. And there's 2 main types. One is the time-restricted fasting, which you eat a certain amount of time, hours of the day, and then you fast for the other hours of the day. You can also eat 5 days normally and 2 days fasting. In those fasting days, you actually can consume 500 to 700 calories, but it's much less than usual. Or you can do the alternate day fasting, which is eating normally one day, fasting the next day. Again, it could be a small number of calories in the alternate day, fasting in every other day. So it's been studied a lot. It continues to be studied a lot. There's a lot of current projects out there studying this. But just basically, there is a reduction in fat mass in people who use intermittent fasting. Systolic blood pressure is a little more. Some studies showed an improvement, some didn't show an improvement. Insulin levels, a slight reduction, which is a good thing. And then fasting glucose levels, especially in the subgroup analysis for people with obesity, definitely improvement in glucose levels. So there is good evidence that it works. Again, it's just another tool. So if you have a person who has to eat breakfast at 7 a.m. and they have to eat dinner at 7 p.m., they're probably not going to be great intermittent fasters. On the other hand, there's quite a few people who say, I don't really get hungry till 10 or 11 in the morning, and so this might work for them. Does it fit in their natural eating pattern is the question. So clinically, we try to explore what the person, their style, what are their favorite foods, what can they not live with, what can they not possibly think they can never eat that again. So if people love rice and they love carbs, they're not going to do well on a keto diet. They're just not going to, right? So you're not going to go down that path. On the other hand, if you find somebody who doesn't really like those, and especially if they have diabetes or they're on the spectrum, then that would be something to pursue them because they actually do really well with keto. And again, there's the calories that we're aiming for. All right, so activity level. For weight loss, what do you think would be the most effective activity for weight loss?
Intermittent intensity exercise.
Intermittent intensity. So that's often something that people choose because there is really good evidence that it does burn fat. But it's another trick question, sorry. The truth is, and it's a very, very strongly held belief, especially by a lot of physicians I know, that if people would just exercise more, they would lose weight. And actually, there's really good evidence that that is not true. It's really, really hard to exercise off weight. It's very important for weight maintenance. So say you've never really had a major weight problem in your life and you exercise, it's great for that to maintain your weight. It's also super important if you've lost a bunch of weight and you want to maintain it, because remember your metabolic rate is lower. So the way to try to be more metabolic is to exercise. But to actually lose weight, it doesn't work. And this kind of is a display of how. So this yell out A, B, C, or D. What do you think it takes a person that weighs 150 pounds walking a 20-minute mile to burn off this lovely Krispy Kreme? D. It's actually C. It takes upwards of 60, an hour and a half to burn off one donut. And who just eats one donut? Like I usually eat 1.5 or something like tear the half and eat. Yeah, so this is an example of if you don't talk with people about how they're eating or what they're eating, and they really want to exercise, it's great. We love exercise. We promote exercise. It's good for many, many things, but it does not work for weight loss unless you also address the eating. So this is from the American College of Sports Medicine, just the amount of time that is recommended for people. And I just want to highlight, to prevent weight gain, it's 180 minutes per week. To prevent the weight regain after loss, look at that, 300 minutes per week. So an hour at least 5 times a week. So it's a lot in order to maintain the weight loss. It's kind of discouraging, actually. Just a real quick question about the elderly, which is actually, I guess, our category too, 65 and older. Exercise is actually helpful for them because of sarcopenia and because of balance and all this. This study just shows that we do promote exercise in that group just for overall health, not so much for weight loss, but for overall health. Okay, so that's the end of my part. I'm going to hand it over to Grant. Any questions about any of that so far? Or we hand over?
This one also shared. Yeah.
All right, thank you, Dr. Latari. So I'm going to now cover pharmacotherapy and surgical therapy. Okay, so let's start with pharmacotherapy. So when we think about the management of obesity, everything Dr. Latari covered is very important, right? Lifestyle as the foundation of how to manage this. And not just for the weight, but also for the person's overall health. If you think of them holistically, all the things you mentioned are good for health and has a lot of benefits in addition to the weight loss that you can achieve with that. So what is the role of adding medication on top of that foundation? So if you think about it, all of the current medications we have for obesity all work primarily the same way. What they do, with the exception of orlistat, and we'll talk about orlistat in a little while, is they help to reduce your appetite to limit your food intake. And as she was saying, it's hard enough as it is to adhere to the behavioral change and the diet changes we're asking. And so if you can imagine, if your appetite is controlled and you're not fighting hunger all the time or thinking about food all the time, how much easier it is to adhere to the prescriptions for diet, for activity, and for the behavioral change. That in turn can lead to a reduction in calorie intake, energy deficit, weight loss, and improvement in health. Okay, so that's the role of medication in the big picture. So I'm just listing for you here the current FDA-approved anti-obesity medications. There aren't a lot. There's going to be a lot more coming down the pipe, so just be prepared for that. But as of now, these are the current FDA-approved medications. We're not going to cover these in detail. We figured that for the purposes of today's lecture, we'll just cover more the general use of these medications. As you start treating patients with obesity, then you'll have to get more familiar with the details of these medicines. But there's phentermine in combination with topiramate, naltrexone in combination with bupropion, orlistat, liraglutide, semaglutide, tirzepatide. And especially the more recent ones, you probably are familiar with that. They're all over everywhere, commercials in the press, and you're hearing a lot of information about those medications. Okay, so how do these medicines work? Like I said earlier, they work by reducing appetite and reducing your food intake. So let's see biologically how that's happening. So as Dr. Latari mentioned, I'm going to pull forward some information from part 1 where we covered the biology. But here's a schematic showing, again, the main central nervous system areas that are involved in weight management. Okay? So down here you'll see that this is the, below the dotted line would be the, it's not working, let me see. Below the dotted line would be the arcuate nucleus of the hypothalamus. There are two main neuronal complexes in the arcuate nucleus. There's the orexigenic, which is appetite stimulating, and the anorexigenic, appetite reducing. Okay? So now let's overlay on top of that these specific medications so you have a better understanding of exactly how they're working. So let's start with the POMC CART anorexigenic in red on the right. And you'll see there that you see the GLP-1 receptor agonist, bupropion, and phentermine. Now, all of those medications activate the POMC CART neurons, which is again anorexigenic. If we go up, you'll see that they talk to the second order neurons and ultimately reduce the body fat stores. In the middle there, you'll see naltrexone, which acts to stimulate the alpha MSH, and that in turn talks to the second order neurons, again going up, reduces the body fat. At the second order neuron level, you also will see GLP-1 and GIP. That combination is tirzepatide. So there are a lot of receptors at the second order neuron level that are controlling appetite and weight. For GIP, we don't really know exactly how that works yet, but we do know somehow in combination with GLP, it's very potent and highly effective. And then finally, on the left-hand side, in the green, you see the orexigenic neurons. The pyramid acts to block that neuronal complex. Okay, so ultimately that does lead to reduction in body fat stores. Okay, so again, you can get an idea now how these medications are working. Here, I just wanted to show you that within the brain itself, there are a lot of locations where they have both GLP-1 as well as GIP receptors. So there's a lot of potential areas where these medications can be acting. Okay. The other pathway, if you remember, we looked at is that of meal initiation and meal termination. And we said there's only one hunger hormone, Dr. Latari mentioned it, which is ghrelin. But for meal termination, there's a whole host of different hormones involved. And I just wanted to highlight a few. So you'll see at the bottom, GLP-1. So now you can start to understand how a GLP-1 receptor agonist can help stimulate meal termination, allowing you to feel full, to feel satisfied sooner, reducing the size of the meal and the amount of food that you take in. I will also highlight amylin, because amylin is currently being researched as another potential anti-obesity medication. But here's the point, which is the more we understand the underlying biology, the better we can develop medications to treat obesity, because now we know how these pathways work, and we can figure out where in the pathway we might be able to affect the overall biology. So very fascinating, very interesting, but I think that accounts for why you're starting to see the kinds of revolutionary changes in the medications coming out now. Now, there also are some peripheral actions of these medications, so I'll just call out a few. So the GLP-1 receptor agonist, besides working on the brain, can also work peripherally as well. And you'll see that the receptors in the GI tract, it slows down the gastric motility, reduces the passage of foods to the stomach. The end result is the same, which is to reduce, is to give you that sense of fullness, the sense of satisfaction earlier, limiting the size of your meals. I did mention orlistat earlier. Orlistat is the only one that only acts peripherally. It's a pancreatic lipase inhibitor. It partially inhibits the hydrolysis of triglycerides and thereby reducing your intake of calories that come from fat. Okay? So what are the current indications for pharmacotherapy? BMI greater than or equal to 30, or greater than or equal to 27 if you have weight-related comorbidities. You also can consider using medications at lower BMIs if the patient has been consistent in following lifestyle, but still has not been able to achieve either their weight or their health-related goals. Okay, again, I said earlier, I'm not going to cover these medications in great detail because it's just too much to absorb right now, but I am going to cover some general guiding principles and how best to use these medications. So first of all is use it as an adjunct to lifestyle. And I talked about that earlier, but this is a good study that shows the additive effect of medication plus lifestyle. So you can see at the top line in purple that that's what happens with medication alone. In the green below it, you can see if you add behavior modification to medication, you get additional weight loss. And then if you intensify the behavior modification by doing meal replacement, which allows you to more closely regulate the amount of calories an individual is taking in, you get even more benefit. So there is an additive benefit of using medication in combination with lifestyle. In addition, if you look at all of the major clinical studies that have been done for the current medications, they all have a lifestyle component, both in the placebo arm as well as in the treatment arm. And this just gives you an example of the kinds of lifestyle interventions that are done in these trials. Most of them, there's a moderate reduction in calorie intake, increased physical activity, as Dr. Latari covered, and then plus minus, there might be more intensive counseling in addition to that. So here I'm trying to show you schematically the major pharmacologic trials, and in red you can see the treatment arm, in gray is the placebo arm, and you can see that even in the placebo arm, which is lifestyle, you're getting some weight reduction, maybe anywhere from 1 to 3%. But keep in mind also that in the red treatment arm, all that benefit is not just medication alone, that's the additive benefit of medication plus lifestyle. Now this is changing now because of the newer generation GLP-1 type medications. Because as you go to the right, like tirzepatide, the amount of weight reduction you're getting with the medication is so much greater compared to the placebo lifestyle that actually the lifestyle is becoming a smaller and smaller component of the total weight loss. You know, before when you're getting weight loss maybe 5, 7, 8%, and lifestyle is contributing 2, 3%, that's a major contribution. But when you're talking 15 to 20% with medication, then the proportion that's attributed to lifestyle becomes smaller and smaller. Not to say that it's no longer necessary, but the conversation changes. So it makes sense now that, not to say, oh, lifestyle doesn't matter, just take the medication. But lifestyle still matters for all the reasons I said earlier. This is important for your overall health and well-being. There's a lot of benefits to these things besides just the weight loss. So definitely it still remains a foundational component of our treatment thinking. Next is to know the specific contraindications and adverse effects of these medications. That's in any area that you go into for the first time, becoming very familiar with the medications that you will be using. And again, we're not going to cover that in detail. I am including this slide just as a point of reference, and I also included that as part of our handout as well. So when the time is right and you need it, you can reference a chart like this, okay? I will quickly mention the reproductive age women and anti-obesity medication. So this one you need to pay attention to because all of these medicines are contraindicated in pregnancy. And I think you can understand why. You don't want to be actively trying to help a woman lose weight while she's pregnant. Because in a healthy pregnancy, you want her to be gaining weight to support the fetus. Second of all, we really don't have great evidence around the actual potential harms of these medicines in pregnancy and in lactation. So to err on the side of caution, we use these medicines cautiously, but definitely in pregnancy, they should not be used. Now, how about in the pre-pregnancy phase? Well, that's appropriate, but again, be careful. Definitely have the conversation around effective contraception if you're going to be on one of these medications. And if they plan to become pregnant or they have an unplanned pregnancy, you would stop the medication at that time. But we want to highlight phentermine to pyramate combination specifically. This one has known teratogenic effects, especially in the first trimester because of topiramate. And if you want to prescribe it, you have to go through specific risk training in order to do so. Personally, I wouldn't even use this medication, definitely not in pregnancy and not in this age group either because of the high risk. There are enough other alternatives that I would stay away from the use of the medicine in reproductive age women. Next is agree on realistic expectations regarding weight loss goals and health-related goals. And so here's sort of a table to help you with that conversation. And we will use a table like this and sit down with the patient before we start a medication to go over their comorbidities, understand what their weight loss goals are, and then show them, what kind of benefit they can expect to receive. So one of the main points of showing you this chart is to show you that even at weight loss levels of 4 to 5%, you can actually start to begin to see pretty significant clinical benefit for a lot of these very common conditions. Now, definitely the more weight you lose, the more benefit you'll get. But to at least start to receive benefit, you don't have to lose 15, 20%. So patients often come in expecting that they need to lose that amount, but they really don't. So this is helpful in order to, again, set realistic expectations around how much weight loss you really need to have and when can you start to expect to see benefit, okay? I did highlight in red semaglutide because this is the first time in a clinical trial a medication has been shown to reduce major cardiovascular events. Okay, it's been shown to reduce factors that could lead to it, like high cholesterol, blood pressure, blood glucose. But in terms of actually showing benefit for MI, stroke, cardiovascular death, this is the first time that's been the case. So I think, again, this represents probably the beginning of more and more to come, where medications are going to be shown to show this kind of benefit. This is an important one, which is to reduce the dose, substitute, or discontinue weight-promoting medications, okay? So what are some of the common medicines that can cause weight gain? Very common medicines, huh?
Steroids?
Steroids, good, yeah.
SSRIs.
SSRIs, antidepressants, very good. Any others? Okay, so even though I practiced internal medicine for a while before doing obesity medicine, I kind of knew this concept, but I really didn't pay much attention to it, but now I fully appreciate this. And the contribution this can make to obesity. Okay, and that, again, be clear, we're not saying that every patient on each one of those medicines is gaining weight because of the medicine. We're just saying they have the potential in any given patient to cause weight gain. So go through the med list very carefully and figure out if there are medications that potentially could be causing weight gain. Okay, so some of you already called out important ones: antidepressants, steroids. The diabetes medications, unfortunately, a lot of them can cause weight gain, and most especially insulin. So a lot of type 2 diabetic patients have obesity and are on insulin. So definitely pay attention to that one. But in addition to that, there's a whole lot of other medicines that are very, very common that can also potentially cause weight gain. So pay close attention to the medication list and see if you can identify some. I'm including this also as a reference for you. I also included this in your handout. But this shows the different classes of medicines that can be weight promoting, and it gives you weight neutral and weight losing alternatives. So definitely try and see if you can find something that still effectively treats the condition for which they were started on that medicine. So you don't want to compromise that, but at the same time is not potentially contributing to their weight gain. It does, in practice, turn out to be a bit of trial and error. So if you identify something that you think might be causing weight gain, you could stop it, reduce the dose, or change it, and then see what happens. In some patients, it may make no difference, but in others, you'll see the difference. Okay, so but just pay attention to these medicines. Individualized medication selection. So this came up in our patient yesterday, Miley Wong, that when you're looking at a patient that has obesity, look at all their other medical problems as well, and see if there are medications you can use that could effectively address more than one condition. So obviously with type 2 diabetes, GLP-1 receptor agonist, tirzepatide, with semaglutide showing cardiovascular benefit. If you have obesity plus cardiovascular disease, semaglutide would be a good choice, and so on and so forth. So you get the idea, which is, are there other conditions that could be treated with the anti-obesity medication that you're thinking of? Second of all, I mentioned adverse effects and contraindications earlier. So that can also help you narrow which medicines would be appropriate for a given patient as well. So take that into consideration as well as this to figure out what might be the best medications to consider for an individual. Next is these medications are designed to be used long-term, both for weight loss as well as weight maintenance. And this is a very dramatic example of why that's the case. So this is a semaglutide trial that went out quite a long time, 68 weeks. And the medication was stopped at 68 weeks, but the patients were continuing to be followed for like another year. And you can see what happened once the medication was stopped. And why do you think that happened? Why did the weight go up so dramatically when the medication was stopped? I'll show you. So I'm going to bring this out again. This is why. Yeah. Okay, so if you remember the slinky, if this is your body weight set point, when you lose weight, there's a tension created that wants to get your weight all the way back. So you start the semaglutide and the weight comes down and you're doing really great. That's the first part of the chart. And at 68 weeks, you stop the medication, but this tension is still there. So the medication was helping, but now it wants to go back up. So you can see that the patients regain about 2/3 of the weight they have lost. So metabolic adaptation doesn't go away with medicine, okay? It's still there underneath the surface. And this is a good example demonstrating that. Which is why the medications are intended to be used long-term. Now that's not always easy, both from a compliance perspective as well as the cost perspective, given the cost of these more recent medications. The other reason, as Dr. Altari mentioned, is obesity should be thought of as a chronic disease. So think of it in the same way as when you treat hypertension or diabetes. You don't just treat till you get to the target and stop the medicine. You still keep them on the medication because you need to maintain it with the use of the medication. So think of obesity in the same way. Finally, once you start a medication, you can discontinue, add, or change it if there's little or no response. So with all of these medications, you'll know pretty early on whether the person is a responder or not a responder. And we consider a clinical response of greater than or equal to 5% weight loss at 12 weeks. But this graph shows that even around 8 to 10 weeks, you pretty much know if they're going to respond or not. And so there's no point in continuing them on the same medication, hoping that 6 months or 12 months down the road, suddenly they'll start to respond. They're not going to respond. So it's better to make that decision early on and make your changes at that time. Okay, so here's a summary of the medications that we've been talking about. Below the red dotted line are like the older generation medications, and they're not bad. I mean, you can see that they can be quite effective. Again, I just put in lifestyle with each one of them just to reinforce that point that the benefit you're seeing is with lifestyle plus medication. But what's amazing is above the dotted line, which are the newer generation anti-obesity medicine. Semaglutide, tirzepatide just being the first of this newer generation, they're getting dramatically higher levels of weight loss, 50, 21% with the medicine. That's almost unheard of, like with the older generation medicines. So they're getting close actually to the level of bariatric surgery at this time. There's a lot of new medications in development, as I was saying earlier. This is just a partial list. So there's an oral GLP-1 agonist for obesity. There's one already for diabetes. We saw that in Miley Wong, but now they're working on one for obesity. And then what's really, a lot of them are built on the GLP-1 platform, as you'll see, different combinations, even triple combinations now, but all based on the understanding of the underlying biology. So everyone's trying to take advantage of that understanding and figure out what other things can be added to get weight loss. An interesting category are the monoclonal antibodies. So bimagrumab is interesting in that it's showing not only a reduction in fat mass loss, but increase in lean body fat mass. Increase in lean body mass, which is really amazing. So you're losing fat and gaining muscle, which is unheard of in a medication. So there's more to come. That's very fascinating, and hopefully it's something that will actually pan out to be effective over the long term. Okay, let's talk about bariatric surgery. So here are the most recent numbers in the US around bariatric surgery, and you can see that 2/3 to 3/4 of the procedures being done is a sleeve gastrectomy. Another third to another fourth is the root-wide gastric bypass. And those are by far the two most common bariatric procedures being done. Adjustable gastric band and the biliopancreatic diversion are much smaller in terms of numbers. So we're not going to really focus on those. Now you might be asking, like in the age of the GLP-1 receptor agonist, what's happening to the volume of bariatric surgeries? It's too soon to tell, but at least one early study shows that between 2022 and 2023, there was a 9% reduction in the volume of surgeries. We'll have to see if this turns out to be a trend or it's just a temporary phenomenon. But I wouldn't be surprised if it does turn out to be a trend over time. So again, here are the most common bariatric surgery procedures, and hopefully this is going to work. I wanted to show you quick videos. If it doesn't work, I'll just talk through them. Try again. Oh, yeah. Oh, this might not connect. Okay, I don't think that's going to work. Okay, sleeve gastrectomy. Sleeve gastrectomy, this pencil doesn't work either. I'm just trying to describe it with words. So sleeve gastrectomy, basically you're resecting a big portion of the stomach. Let me see. Yeah, you're resecting a large portion of the stomach, basically leaving behind like a tubular stomach. We call it like a banana if you want to think about it. And that's sort of the residual stomach that's left. Everything else is left intact. The root-wide gastric bypass, if you think about it, we are creating a small gastric pouch of the proximal stomach, pictured at the top, and then we're transecting the small intestine lower down and bringing the small intestine up to that gastric pouch. That creates the gastric bypass. You're bypassing the stomach. So food no longer goes to the stomach, It goes from the esophagus into the small gastric pouch and directly into the small intestine. The stomach, along with portions of the duodenum, then re-anastomose lower down in the intestinal tract. Okay, so that's the gastric bypass. Sorry about the video not working. Okay, so what are the indications for surgery? So until recently, we were following the 1991 NIH guidelines, which said that surgery was indicated for BMI greater than or equal to 40 or greater than or equal to 35 if you had comorbidities. In 2022, the guidelines were updated based on the more recent evidence, and basically what they did is they lowered the threshold, because the more recent evidence is showing that even at lower BMIs, patients are achieving clinical benefit. And so the indication for surgery is now a BMI greater than or equal to 35, and you can even go down as low as 30 in patients who have metabolic disease or who have not responded to therapy, including medication up until that point. Okay. The second thing they recognize is that in the Asian population, at lower BMIs, you can start seeing the negative clinical effects. And so they lowered the threshold for the Asian population so that BMI surgery can be offered at 27.5. Okay, so basically the evidence with more and more studies is showing that even at lower BMIs, you're getting clinical benefit that makes surgery worth doing. I put on one chart everything we've talked about up until now, just to give you an overall sense of, based on the class of obesity an individual has and the different therapeutic options that are available, what makes sense to start when for any given individual. So you can look at this later. Okay, so what are the long-term weight loss for bypass surgery? The best data we have goes out 10 years for room-wide gastric bypass. And you can see that you can get a weight loss of 21% at that point. If we want to see how that compares to sleeve gastrectomy, we don't have as much good long-term data for sleeve gastrectomy because it hasn't been around that long. But you can see already at 4 years, sleeve gastrectomy is getting like 18% weight loss. We'll have to see over the long term whether that holds out or not. In terms of major clinical outcomes, definitely great benefit with bariatric surgery for overall mortality and for major cardiovascular outcomes. So definitely surgery is highly effective in those with higher classes of obesity in terms of achieving these kinds of outcomes. Although we're not talking specifically about diabetes today, I just wanted to highlight that bariatric surgery in terms of its effect on diabetes is quite significant as well. So this is one study that was comparing surgery to medical therapy, and you can see the big difference between the effect you get with bariatric surgery compared to medical therapy. And here's another collection of 4 clinical trials that were pooled together, and you can see the same significant benefit with surgery in terms of diabetes. I just highlighted in red remission of type 2 diabetes. So at 7 years out, like nearly 20% of patients are in remission, which means that their blood sugar is controlled without any medication at all, just from doing this procedure. So quite remarkable, probably related to hormonal changes that happen after surgery, but this is amazing to me. And Dr. Lutari can give her stories, but even like a day after surgery, their blood sugars and the amount of medication you have to use drop dramatically. I mean, they haven't lost any weight yet. They just had the procedure done, and already you start seeing these phenomenal impacts on diabetes. So really amazing what happens with bariatric surgery. Not that we fully understand all the mechanisms, but definitely it does impact diabetes significantly. So in terms of the effectiveness of bariatric surgery, still is for the higher classes of obesity, greater than or equal to 40, but now, for lower classes of BMI, the most effective treatment that we have. And that's in terms of the degree of weight loss that you can obtain, the durability of that weight loss over time, and then the improvement in clinical outcomes. Okay, so it is still an effective therapy for those who do need it. I'm going to add a however, and a lot of the howevers are based on these newer generation medications. So in terms of the degree of weight loss achieved, like I showed you earlier, Tirzepatide is getting results close to that of bariatric surgery. Okay. Now, in terms of durability, I still think surgery has the advantage over the long term, being able to sustain that weight loss. Improvement in clinical outcomes, definitely surgery, as I just showed you, significant benefit. But with the semaglutide trial and probably more to come, I wouldn't be surprised if medications more and more start to show benefits approaching that surgery in the future. So just be paying attention to that. Now, how does weight loss happen after surgery? But what are the mechanisms at which that happens? Now, historically, we thought it was primarily due to a reduction in calories. You just have a much smaller stomach, like I showed you. You just can't eat as much. You can't hold as much food, so you end up just eating and consuming less calories. And then for the gastric bypass, because you're bypassing a portion of the small intestine, there's a component of malabsorption as well. But what we're discovering as we understand the biology more and more is that definitely hormonal changes are another key mechanism by which people lose weight after surgery. There also are things like reduction in the reward value of high-calorie, high-density foods. And we notice that too in clinical practice. Patients after surgery will say their food tastes change, their food preferences change. We don't know exactly why and how all that happens, but definitely it does happen after surgery. And then research is being done on changes in the gut microbiome that also might play a role in reducing weight as well. So in terms of metabolic or hormonal changes, I'm just going to highlight a few. So you can see that both for gastric bypass and sleeve gastrectomy, that there are changes in the hormones that go in the direction of weight loss. So for example, ghrelin, the significant reduction in ghrelin, the hunger hormone, CCK, PYY, GLP-1 levels all go up. If you remember the earlier diagram, those are all meal termination hormones. So all these levels go up, you get earlier meal termination, earlier fullness, satisfaction with your meal. Now, what might be some reasons for weight regain after surgery? So you've had your surgery. What might be reasons for gaining weight after that?
Eating calorie-rich foods, like you might not be intaking a lot quantity-wise. So maybe whatever you're eating is high.
Yeah, so high calorie, calorie-dense foods, liquid calories. Yeah.
Soda, chips.
Yeah. Okay, good. Very good. Any other thoughts? Why someone might regain weight after surgery?
Maybe it's like a mental component, maybe some sort of like anxiety or depression or mental health issue which causes them to eat more than they actually
Yeah, that's how we talked about that, right? How that can affect your eating behaviors. Yeah. So mental health issues that come up after surgery, good. Anything else? Okay. You might be surprised that there is weight regain after surgery. Some people might think, oh, you've had the ultimate treatment, you're one and done, you're good to go. But there is weight regain after surgery. Now, some of it is, like we said, there's some metabolic adaptation probably happening. So what we notice in practice is that after surgery, you get about a year, maybe sometimes a year and a half in some of my patients, where they will continue to lose weight. But then that honeymoon period does have an ending. There is a point at which the weight loss stops and the weight plateaus, and hopefully they do not start to regain weight from that point forward. And there are multiple possible causes. You've called out a few: high-calorie foods, liquid calories, maybe some mental health issues that change your eating habits. All those can contribute, similar to the things that can cause weight gain before surgery. In addition, there might be some anatomic, structural things, enlargement of the gastric pouch that I showed you in gastric bypass, maybe some enlargement of the stoma, so food is passing through more quickly. So there could be a multiple number of reasons. And then I just wanted to highlight again that there are probably hormonal changes that happen. I just showed you what happens after surgery, but there is a point at which those hormonal changes start to get back to normal after a certain point, and then you're dealing with the same sort of metabolic adaptation as before. Now, more recently, we're more aggressive in using pharmacologic therapy after surgery. So liraglutide, topiramate, phentermine combination have the best evidence, but starting medication early on is better than late. So if you notice weight regain, if you are thinking of using medication, better to start early. So here's the key question. Does bariatric surgery reset the weight set point? That's a key question. So I just gave you a quote from one of the bariatric surgery researchers who believes that actually there is a resetting of the set point, maybe about 20 to 30%. In clinical practice, that does seem to be the case. If you look at the clinical evidence, as I showed you, that what accounts for the ability to maintain a 20% weight loss over a long period of time, probably there is some resetting of the set point in the case of bariatric surgery. Okay, so we've covered lifestyle, we've covered medication, we've covered surgery. So those all help with weight loss. Now the question is, can you maintain that weight loss over a long period of time, right? So can we flatten the curve? And so one source of data that's very helpful is called the National Weight Control Registry. And this is the registry of patients that have been able to lose, well, in order to get into the registry, you have to have lost at least 30 pounds and kept it off for 1 year. And if you look at the patients in the database, there are over 10,000 now in there. Most of them have lost like 60 plus pounds and kept it off for 5.5 years, which is quite remarkable. So in a way, we're looking at a subset of individuals who have found a way not only to lose weight, but to keep it off successfully for quite a long period of time, okay? Now, if you ask these individuals, okay, so this is not a prospective study, this is like a database. But if you survey these patients and ask how many are on medication, only a very small percentage are taking medication. So this mainly reflects lifestyle and whether or not lifestyle can allow you to maintain your weight over a long period of time. So what are some of the things you think are common within this select group of individuals that have allowed them not only to lose weight, and quite a lot of weight, but keep it off for a long time? Have they found some secret that nobody else knows about? Any ideas? What are these people doing?
Sustainable habits.
Sustainable habits, excellent, yes, sustainable habits. Critical. Sustainable is the key word there, sustainable habits. Okay, very good. Other thoughts? How are they able to do this? Okay, well that's a good summary because basically that's what it comes down to. Yeah? So if you look at these individuals, this is what's common amongst them. So first is a moderately low-fat, high-carbohydrate diet. And I'm going to temper that with what Dr. Latawi shared earlier. So I don't know if this is saying if you're on this specific type of diet, this is what is key to maintaining your weight versus finding a diet that works for you and just sticking with it, being consistent with it over the long term. I think that's probably what this is demonstrating. Self-monitoring, Dr. Latawi mentioned, so no surprise, that self-monitoring of your weight and your food intake on a constant, consistent basis is critical, right? Noticing changes right away and making changes right away, rather than letting things get out of hand. Eating breakfast regularly, high levels of regular exercise, often intense, and then limited TV viewing, I think, is a proxy for low levels of sedentary behavior. So again, things that you probably would say, yeah, that makes sense, that if you're able to do these things consistently and well over a long period of time, that can help you maintain the weight loss. So do you think these individuals have reset their set point? So we're saying that surgery, yeah, maybe to some degree is resetting that. We're saying medications, no, because if you stop them, the weight goes back. So now the question is, if you're able to maintain your lifestyle for a long time, are you able to reset your set point? Hard to know, yeah. There's no good research being done to answer that question. I would say in practice, it seems to be that there is some resetting because when you have patients like this, they will tell you that over time it gets easier to maintain their weight. The amount of effort it takes to be able to maintain the weight starts to go down over time. Now, some of that could be what were not habits initially have become habits, so they're more automatic. I can see that. But it could also be that there is some resetting of the set point so that they're not fighting that set point constantly as they were at the beginning. So we do want to end on a hopeful note. I know there's been a lot of sort of pessimistic things that we've communicated, but there's truly, I think, reasons for hope in the management of obesity. And first is what we mentioned earlier, that our understanding of the biology is getting better, more sophisticated. And the more we understand about the biology, the better we'll be able to design medications to target the treatment of obesity. We looked at surgery, still highly effective over the long term, so that's not going to go away, so definitely that's a positive. And then the durability of weight maintenance in this select group of individuals, I think, also gives hope that if you are able to have discipline and determination and consistency over the long term, that there's the potential for not only losing weight, but maintaining that weight over a long period of time. So again, what we try to cover today is treatment, and we cover the behavioral-based lifestyle program, cover diet, activity, pharmacotherapy, and some of the general principles in using the medications, and then the outcomes and effectiveness of bariatric surgery. So we'll just do a quick PS, which is that the American Board of Obesity Medicine is a recent board. We're both board certified in that specialty. It's an exciting field, and if you have any interest at all in this, we would highly encourage you to consider becoming board certified in this specialty. But thank you for your time. It's been fun, and we'll have some time for questions.
Clinically, have you noticed an increase in set point in postpartum women? So, like, having one set point and then going through pregnancy, do you notice that the set point tends to increase, or does it usually tend to stay about the same?
That's a great question. Definitely the set point changes for most women in pregnancy. So when we would do an intake, we actually had like a 16-page questionnaire they had to fill out. And one of it was, what is your history of weight? So if you were overweight from the time you were a kid, there's kind of maybe some genetics or something involved. But for many, many women, it was their birth of their children. Things change after that. Of course, lifestyle changes after that too, right? The amount of time you have to exercise or like food prep and that kind of thing. Yeah, that is definitely a very common kind of life experience that changed at that point. I'm not sure if it's ever been studied specifically, like someone's actually done their metabolic, rates. It probably has, but yeah. And I also want to just mention from an OB point of view that we have a standard amount of weight gain that we recommend during pregnancy, right? But if you have a BMI over a certain range, that amount of weight is actually lower. So we definitely don't want them to lose weight, but we also try to have them not gain as much weight, so they kind of metabolize from their muscle. So big.
What's the insurance coverage like for some of the medications patients don't have the other chronic diseases that the drugs are used to treat?
It's probably the best question of the day. It's terrible right now. It's terrible, and it's because it's so expensive. The GLP-1s are, if you just bought it, it's $1,000, $1,100 a month. If you just bought it straight. When there was a shortage of them, the FDA approved the compounding of the semaglutide and the retatrutide, but that's actually officially off the table now because they've caught up and they have enough production. So people were getting it for more like $300 a month and compounded pharmacy. As far as I know, there are no health insurance companies in the state that are currently covering GLP-1s. So there's a huge issue of disparity of who can afford it, who can't afford it. It really irritates us and kind of burns us. And I'm hoping by the time you guys are practicing and prescribing, we'll kind of have that figured out, and there'll be more generic options. Drug companies, of course, like to continue to add other indications so it stays in a non-generic category for longer. Yeah, they'll get you start.
Yeah, that's the issue. I mean,
Yeah.
it goes to the point I made earlier, which is in order for these medications to be used effectively and appropriately, it's long term. But who can afford $1,000+ a month for one medicine? So it's not really feasible a lot of times. Not that they don't want to, or it's not working, but it's just not affordable. Now the manufacturers, somewhat to their credit, have reduced the price recently so that it's a more reasonable $500 a month if you want to pay without insurance coverage. With tirzepatide, I've seen it anywhere from $500 to $700 a month based on what dosage you're on. But that is definitely a real issue.
And they are, as Dr. Powell mentioned, they're developing the oral versions of GLP-1s. There's currently one with the indication for diabetes. One of the things that makes Ozempic and Wegovy and those things so expensive is the really fancy little pen that it comes with, and you just crank it. It's super easy to use, but that's expensive to produce that pen and use that pen. So the oral versions will be less expensive in general. And then I just want to say again, some kind of hope. Like when I first kind of got involved with weight management, we were actually having to present every year how important it was for us to have a bariatric surgery program. Like we had to go and like show all the data, and it wasn't really considered. It was standard practice, but it was still not covered by anybody else in the state. And year after year after year, we went. And we got it, and eventually it became really standard, and now, we have a really good surgery, we had a really great surgery program. So it kind of reminds me of that now, where there's still a lot of stigma around obesity, as we talked about in part one, and there is this kind of for-profit issue that we have. But I think there will come a time, hopefully, when you folks are practicing, that we will have more access to universal access to a treatment that's very, very effective and safe.
Have there been any medications looking to target cortisol levels in hopes of stimulating the POMC pathway?
Stimulating cortisol levels.
Like, has there been any, I guess, research into trying to boost up the natural metabolism? So if you could maybe decrease the cortisol levels, maybe you could try to endogenously induce the POMC pathway to be upregulated a little bit more?
No, like I was saying, the way the current medications are designed, it's really looking to, they are activating the POMC card system. So either through the sympathetic, the dopamine, norepinephrine reuptake inhibitors like phentermine, or GLP-1 agonists directly activating that. But I don't know if any of the medications in development are targeting cortisol pathways.
I think if I'm not mistaken, an underlying question you're having is there a way to change metabolism, basically? And that's a great question because people come in asking us that I just have a sluggish metabolism, since my kids are born or whatever, I just don't have the same. And it's true, your metabolism does change over time, and there's a lot of after-hours infomercials for things that say increase your metabolism and taking these green tree extracts or raspberry ketones or blah, blah. And those studies are very small studies, very small, and you might see some improvement, but as you talked about, there's also improvement just with lifestyle change. So there's a placebo effect as well in those studies. So yeah, we don't really have anything that we know that changes metabolism, even thyroid. So we had a case, the first case of before was hypothyroidism. And there are definitely people who come to us and want to adjust their thyroid a little bit, like their TSH is really, really low. And there's actually very little effect on weight when you adjust the thyroid. If the thyroid is completely out of whack and your TSH is 20, those people probably are going to have some weight gain, but it doesn't work in the reverse, unfortunately. I hope someday we have something to change that.
Yeah, so in answer to that question to that point is that, the POMC cart neuron, the anorexogenic, does two things. One is reduce appetite and increase energy expenditure. So indirectly, by activating it, you are affecting the energy expenditure. But what she's saying is that what's potentially dangerous would be agents that increase your metabolism where there's no feedback or regulation of it, right? Because if you're working through the POMC system, there's sort of built-in controls over that. But if you have something that's always increasing the metabolism, but there's nothing to control it that you can see would that be potentially dangerous. Yeah. So indirectly, by doing so, you are affecting energy expenditure, but indirectly and using already the natural homeostatic systems that we have.
What are like some side effects associated with like the bariatric surgery or like some of the obesity meds? Because I know like in our diabetes medication lecture, they talked about like potentially diarrhea. And so like when you're removing like part of your stomach or like connecting your esophagus straight to your small intestine, like would you also get diarrhea or like what are like some side effects associated with those procedures?
Yeah, I would say that over the long term, it's really like the vitamin mineral deficiencies that can happen, especially with gastric bypass, because you are bypassing a portion of the small intestine. So long term, that's one of the main things we pay attention to, is making sure that they're getting adequate vitamin and mineral replacement, that we're monitoring that carefully. There's a phenomenon called dumping syndrome that can happen after gastric bypass, because everything is coming through the system so rapidly that actually that can cause a problem. But I would say that's usually short term and not a long term issue for most patients.
Yeah, and it's generally a nutritional education where people kind of get the carbs and stuff that are dissolved. Like you have amylase in your mouth, right? So you dissolve stuff really quickly, carbs, and so they go through really quickly. But they also, your insulin levels and your glucose levels goes high, and that's what leads to the dumping syndrome. So when people have that, we have to counsel them. We ask them, what are you eating? Do they have protein intake with their carbs? Initially, after surgery, it's quite a big lifestyle change for sure. As you said, food is suddenly going like through a very tiny little pouch. It's literally the size of an egg. And so our patients went through several months of training before we did the surgery on them, psychological assessments, and as well as dietary, like what you expect. So if people were trying to eat like they were before, they would be miserable. They would have pain. But over time, there's a pouch that stretch, and they kind of learn what. Medications do have side effects as well. So phentermine, which is the one we've used for a long time, some people feel like they just drank a bunch of coffee, they feel a little energized. Pyramate can cause some word-finding problems that not everybody has, but some people do. And then the GLP-1s are generally well tolerated, but they do cause nausea. So if you've seen them used with people with diabetes as well, we start with a very low dose and we gradually increase the dose because the nausea can be a rate limiting factor. So they do have some side effects, but they're actually fairly well tolerated if you start slow and increase.
In gastric bypass surgery, is the food because you're skipping some of the stomach, how is the food still being digested to the same degree, or is there some concern for that?
It's still being digested, but there are absorption issues. So as Dr. Paul mentioned, it's part of our training for them is they have to be on lifelong vitamin and mineral supplementation. And some people are really good at that, and some people are not so good. But there are chewable bariatric vitamins that make it easier to taste pretty good, and people can eat them. Yeah, it's not so much the digestion as absorption.
And then I don't know how time to pull up the illustration, but in gastric bypass again, the stomach is still there. It's just connected to the small intestine lower down. So eventually, when it comes through the small gastric pouch, it's coming down one track. The stomach hooks up. That's the Y. Yeah, it's a Y. They come together. So the digestive juices and enzymes from the stomach still do mix with the food further down in the digestive system. Yeah. So there's some of that still happening. It's just in a different way. Yeah. Okay. Sounds good. Yeah. Thank you again. Yeah, nothing works.
Because you're connecting later small intestine, but it just makes it not.
How about you?